series, and then you can take up the scientific session.
Okay.
Please display the first slide, Shweta.
First slide is Pinnacle series.
Yes.
Yes.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Postpartum Hemorrhage, organized by Pinnacle News Series in association with Bangalore, Burla, Ludhiana, Gauhati, and Rajkot OBGYN societies. It's my privilege to introduce the MOC of today's webinar, Dr. Radhika Gauri ma'am. Ma'am is the specialist consultant in OBG and clinical lead in ESIC Hospital, Tirunelveli, Tamil Nadu. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti, for the kind words. Good evening, esteemed faculty and delegates. We are into the 8th session of the Pinnacle News Series. The topic today is postpartum hemorrhage. I invite our Sampath ma'am to give a welcome address and start the session. Thank you, ma'am.
Yes. Thank you, Radhika. Chakiti, you can put that prayer song, no? Then we can go with the welcome address.
Okay, ma'am.
Oh. Yes, thank you, Sakiti. So I welcome everyone. This is a Pinnacle News Series. We are always do every month on the second Thursday and the fourth Thursday from 4:30 to 6 o'clock. Since it is societies are taken from north, east, west, and south, it is named as Pinnacle News Series. Today we have the Bangalore Society, Burla Society, Rajkot, Ludhiana, and Gauhati Society. I welcome the President and Secretary of Ludhiana, Dr. Gupta, and Dr. Secretary Dr. Manu Singla, and the Burla Society, Dr. Ojeshwani and Dr. Leena, and Bangalore Society, Dr. Mangala and Dr. Nirmala, and the Rajkot Society, Dr. Jigna and Dr. Karthikeyan, Gauhati Society, Dr. Das Sir and Dr. Kalpana. And we have two sessions. One session being the session of the talk on emotive bundle will be deliberated by Dr. Rekha Rajendran. I welcome her, chaired by Dr. Radhika Gauri. And we have the panel by Dr. Ramani Devi, will be moderating the case scenarios of PPH, and Das Sir will be the expert in the panel. And now I invite Dr. Shashwat she has accepted to be the chief guest and Dr. Ojeshwani to be the guest of honor. I invite Dr. Shashwat. Sakiti, give the CV of Dr. Shashwati Madam. Shashwati Madam is known to me from Guwahati for many years, and she is a simple and humble person. And she was the past president of Guwahati Society. And she was the chairperson of Medical Education Committee from 2013 to 15, and she is a good teacher and vice president of ISOPAP 20 to 22, president ISOPAP Assam chapter, past president of Cox, and she has given many articles and invited speaker in many conferences. So I now call upon Dr. Shashwati Madam, our chief guest, to tell few words and bless the webinar. Shashwati Madam.
Thank you, Dr. Sampath Kumari, for giving me this opportunity. Now I feel I'm really old when you become the chief guest. It is very nice
no,
actually
to be importance.
Yeah, the importance. Yeah, I do understand this, Chimpa. And I'm really happy that you are bringing all the societies together, that small and big, you are not taking care of every society, small societies also. And you have this time, it is the 8th episode, as I can see, and you have brought out a very, very important topic of discussion. And one of the topic in this thing is emotive. I think a lot of people are not acquainted with this particular emotive, that module for the management of PPH. So I'm sure this is going to give a lot of light within the new knowledge, acquiring new knowledge in relation to postpartum hemorrhage. And it is very also nice to see the speakers are from the very young generations also, who will be taking part in this management of case-based management of postpartum program. So that is really nice to see. And I'm so happy to be a part of this meeting. And if Sampath calls me, I cannot say her no, because she's a very close friend of mine. And number of times she has given me the chaklis, the murukkus of their place. I'm so happy for that. Yeah, and it's really nice to meet all of you together. And I wish this particular Pinnacle a great success, and a lot of people get the new information. Especially, I'm very, very fascinated with that you have put that emotive module in this case. Thank you so much.
Thank you, madam, for being the chief guest. Next, I invited Dr. Ojeshwani. She is a guest of honor. Sakiti, can you give if time permits, it's only 1 hour program, Shashwati madam. If time permits, be here.
Let me see, if possible.
Yes, madam. Can we have the CV of Dr. Ojeshwani? Dr. Ojeshwani Patel is ex-executive member of East Zone Chairperson, ISOPAB, Coordinator, ISOPAB, Burla, and Sabalpur Chapter, and Vice President of National ISOPAB, President of Burla OG Society, and she has many awards to her credits and publications, more than 25 original research, and contributed more than 7 chapters in different books, contributed to the health articles of Odia Health Magazine. Her special field of interest is iris pregnancy and infertility. I think she is an also appropriate person. So, Ojeshwani madam, I welcome you to give few words to the webinar and wish the webinar. Thank you.
Madam. Thank you, madam, for your kind introduction. So, good afternoon, everyone, and my namaskar to one and all. At the outset, I am thankful to the organizers, especially Dr. Sampath Kumari madam, for honoring me as the guest of honor in this great webinar. And the webinar is the Pinnacle News Series, Episode 8, which is on a very basic topic on the PPH, which is a burning issue. And I am also very much thankful to the Master of Ceremonies, Dr. Madhumita Arun Karthik and Dr. T. Radhika Gauri, for their nice coordination for organizing this mega event. I welcome all our speakers and also congratulate all the speakers, chairpersons, experts, moderators, and panelists to this webinar. And I welcome all the office bearers of the different OG societies like Bangalore, Burla, Ludhiana, Guwahati, and Rajkot. I wish happy learning to all the viewers of this webinar and hope it will be very much informative, educative to all. I have earlier also joined in the various academic activities being organized by our great leader, Dr. Sampath Kumari Madam. And she always designed the scientific program very basic, very small event, crispy event, but very basic, which is practical and which is useful in our day-to-day life. And this event is also one of them. And PPH is still a major contributor of the maternal death. Almost 1/4 of the maternal death is due to PPH. And the Sustainable Development Goal target is to reduce the MMR to less than 70. India is doing good, but still we need to struggle hard to achieve this target. And we should remember that every mother's life is important. Every mother counts. So let's try to prevent PPH. If not, then prepare ourselves to handle PPH. The mnemonic of PPH is prevent, prepare, and handle. So that at the end of the childbirth, our aim of healthy mother and healthy child, healthy baby will be achieved.
Thank you.
One thing is that I know our chief guest, Dr. Saraswati Madam, very closely when I joined ISOFAR, and I feel as if we are our same family member. Madam is very much known figure in the FOXY, being the she was the first chairperson of the Medical Education Committee, and she's also a very known figure in the ISOFAR, and she's a true academician and overall a very great human being. And my regards and namaskar to Saraswati Madam.
Thank you so much, Yojashini. So nice of you.
Yes, 1 minute. Yes, ma'am. Dr. Rekha Rajendra Kumar Madam, who is the first speaker of this CME. She is a very good friend of mine, and I wish all the best for her future endeavor as far as FOXY election is concerned. And I have also attended many programs of CMEs of Madam Ramani Devi, who can mesmerize you with her eloquent, confident, and straightforward deliberation. And she is now going to deal with the case-based scenario on PPH. And my regards to Dr. Panchanan sir, who is the expert of this panel, who will definitely give his expert comments and expert opinion. So I pay my regards to Panchanan sir also. And my best wishes to all the dynamic, energetic panelists, Dr. Suhasini, Dr. Swati, Dr. Saroj, Dr. Sarmila, and Dr. Rasmi. And definitely we'll learn a lot at the end of this session. And I'm thankful to this Shield Pharma for their support, and also the ClearNet people. And again, wishing all a happy learning. Jai Jagannath, wish all the best for the webinar. Thank you all.
Thank you, Yojashini Madam. Yes, as you told, this PPH is a nightmare. No one will expect which patient will go for PPH. So always we should be very careful. I always used to tell my PGs, don't forget that 4 T's. Don't tissue trauma thrombin. So that is now we can have, at least I think this will be useful to our delegates and the fund. Thank you, Yojashini Madam. Now I hand over the mic to Dr. Radhika for our scientific session. Radhika slide push. Shashwat, sorry, Sagiti.
Thank you,
I will
ma'am.
introduce Radhika.
Thank you, Sampath, ma'am.
Our first session is, the topic is emotive bundle. The speaker, Dr. Radhika, will introduce. Radhika is our chairperson, our MOC, and she is from Tirunelveli, and she is the professor working in ESI hospital, and she is our routine MOC for many of our TNFOG program. Whenever I call her, she will never say no. So Radhika, welcome Radhika. Introduce the speaker without wasting the time. Thank you, Radhika.
Thank you, ma'am. Thank you, Sampath, ma'am, for your very kind words. And Sahiti, please. I invite Dr. Rekha Rajendra Kumar, ma'am, who is the speaker for this session. The topic is emotive bundle. Dr. Rekha Rajendra Kumar, ma'am, has been practicing for the 34 years, and she is the president. Ma'am?
Please read very short.
Okay, ma'am.
Because madam has given us only 1 hour.
1 hour, okay. She's got lots of credits to her name, and she's won 21 awards and 25 felicitations, including international, state, and Foxy awards, and she's very famous among the Foxy group. And I welcome you, ma'am.
Yeah.
to the
Thank you,
session.
Dr. Radhika.
Thank you, ma'am.
Thank you.
Nice to have you, ma'am. Thank you.
Yeah, thank you. If you close the screen, I will. Yeah, thank you. First of all, let me thank Sampath Madam. Madam, with deep gratitude, I am presenting this. Madam has not only given opportunity here, she has given me opportunity everywhere possible. She has seen to it that she takes care of me so much. Thank you so much. Other than that, what I am presenting today also are the slides of Madam. I have lended the slides from Madam. Thank you for that also, Madam. Thank you, Saraswati Madam, Ojaswini Madam, Das Sir, all for your esteemed presence here. And without wasting much time, I'll continue with my presentation. Yeah, thank you.
All the best for Rekha for her election.
Yeah, thank you so much, Madam. I'm just... Why the share only is not coming? Share button.
Why it's not coming?
That button.
Sometimes it will be there in more option, ma'am. Kindly check.
Now it came. Yeah. I'll make it. Yeah.
We'll go to slideshow, Radhika.
Yes, ma'am.
Yeah, I have done that. Yes.
Yes.
Yeah, thank you. Yeah, that button was not seen. Anyway, thank you so much. So I'm talking today on the emotive. Yeah, emotive. So first of all, let us just discuss very few slides on the introduction of PPH. Postpartum hemorrhage is defined as a blood loss of at least 500 ml, that's half a liter, soon after the birth. That is before the placenta is delivered or just after the placenta is delivered, whatever. It is the bleeding from the genital tract soon after the birth of the baby. Previously, they used to categorize as 500 ml after normal delivery, 1000 ml after the cesarean section, etc., etc. So anyway, it is regardless of the delivery according to the RCOG, Foxy, and the emotive trial. PPH is the most common cause of maternal death, as all of us know, and it is a second life for the woman, the delivery, because of this reason only. So it accounts for about 35%. That's a very great contribution of all the maternal deaths worldwide. Incidence of PPH is around 2 to 4% after vaginal delivery. All of us know that it is slightly lesser compared to a cesarean section delivery, and PPH incidence after the cesarean section is around 6%. So now why we are so much worried about the PPH, why Sampath Madam in particular has selected this topic, and that to the emotive bundle, is because it is the major cause of maternal death, and it happens in flash of time. Before you recognize the problem, before you correct the problem, before you call your staff to help you, the major calamity would have happened. So it takes, as we have shown on the right side of that box, it takes not more than 2 hours for the roof to fall down. In certain other cases, say rupture uterus, we may have few hours, 6 hours, 8 hours, etc. Eclampsia patient may give us some signs like throwing a fit. She may another 2 to 3 days, she may give us time. So we have some time in hand to manage, though critical, but we have some time to manage, matter of few hours in these kind of cases. Sepsis may give us 1 week time, where we become more intelligent, we find a good antibiotic, correct the problem, correct the septic shock, etc. But unfortunately, in PPH, we don't have time in hand. That is why we emphasize on this topic. How many ever times we have spoken on PPH, we repeatedly talk, especially for the juniors. This is very, very important. The postgraduates, very, very important. And the paramedical nursing staff, it is very important. And it is more important for the people who have standalone setup, like the nursing homes or the small setup hospitals. Bigger hospitals like government hospitals, where Saraswati Madam is working, Sampath Madam is working, Das Sir is working, they may have a bigger setup, more people to help, and the blood bank may be there in their hospital. But small setups, blood bank will not be there. Staff will be less. And those staff also, if they are not trained, then the problem is going to mount and get compounded. The uterus can bleed up to 800 cc per minute. So it's like opening a tap. Within 10 minutes, in front of our eyes, the patient can collapse and die. And that is the seriousness of PPH. Now, why there is high mortality from PPH? It is because of the three reasons which we have mentioned. Failure to recognize the excessive blood loss. The doctor who is examining the patient might not have recognized because the underpads are so absorptive that so much of blood has got absorbed and we underestimate that. So the estimation of the blood loss is not estimated properly. Failure to provide the timely treatment for the cause of PPH, maybe because not recognized, maybe because underestimated, or somehow the treatment is somehow delayed and that is not timely. So this is another important reason for the morbidity, shifting of the patient, mortality, interventions, surgeries, etc. in these people. Failure to provide early and adequate fluid replacement and treatment for the shock so that she does not go into the end organ failure. So these are the three main reasons. Now, what are all the challenges in the management of PPH? One is it is the, as we have already told, estimation of the blood loss. You may think that it is not a big challenge, but truly it is. In practice, when the patient is lying down, the blood seeps behind her, that is to the buttocks, and we may not have noticed. We may be just suturing the episiotomy or checking for the tears around or crying of the baby. Ultimately, this has gone off the mind. So estimation of the blood loss is truly important because, as in the very first slide, as I have mentioned, the 500 cc and beyond is PPH. Challenge 2, delayed or inconsistent use of interventions for the management of postpartum hemorrhage. We think not much of blood is lost, or even if it's, you have estimated it properly, you have known the seriousness, you may delay, like the sending for the blood transfusion, like arranging for the blood transfusions or the blood components, or for the next step of the treatment, you may delay, thinking that with this treatment, what I'm doing, giving some fluid, foot end elevation, some oxygen, patient will automatically correct. Hoping for that, you may delay your proper treatment or the intervention for that patient. Treatment for the postpartum hemorrhage are often administered in a sequential manner. A healthcare provider administers an intervention and waits to see whether it has had an effect. So this wait to see is wrong. Don't wait. One has to come soon after the other, especially in the primary treatment, which I'm going to explain in future slides. Everything should happen together. There is no word called wait in this patient, because I have already explained the gravity of situation and how the patient can go from pan to fire. However, postpartum hemorrhage is a time-critical condition, as we have emphasized and cannot emphasize more, and delays in the use of life-saving interventions can result in the unthought of situation, that is loss of life, which is a very, very great loss to that family. Coming to the thing, priority, stop the bleeding. So this is the motto, stop the bleeding. Do whatever you want, stop the bleeding, because the patient develops coagulation failure. All of us know that taken care of or the delayed treatment of this PPH will result in coagulation problem. Once that happens, the DIC happens, then the problem is going to mount multiple folds. Whatever you do, the treatment may not help her. The second important thing is secondary to either because of the coagulation problem or because of hypovolemia and the poor oxygenation, the organ damage from this can happen, and this underperfusion can result in end organ failure, which is also a very unwanted, undesired thing for us. Conservative approaches should be tried first, rapidly moving to the more invasive procedures. This is exactly what we have been telling, rapidly moving to the more invasive procedures. There is nothing to wait. So the thing should happen in a very, very fast pace. So first 24 hours is very, very critical for us to treat, act, intervene, and also to watch how much and where we are. Most deaths due to severe PPH seem to occur during the first 24 hours after the birth of the newborn. The transition of hemorrhage from the compensated to decompensated stage is very rapid. It happens within a wink and easily overlooked. Hence, prediction, early recognition, and intervention are crucial. All the three are very crucial for lowering the risk of severe PPH or improving its clinical outcome. As Sampath Madam said, unfortunately, many of the times you can't even predict. You think everything is fine and she lands up in PPH. Everything normal, smooth progress, delivered normally, baby cried at birth, landed up in PPH. She absolutely did not have any reason. We could never predict. So these are certain scenarios where this kind of action is very much necessary. Need for an effective implementation tool. FIGO believes that the greatest impediment is the absence of an effective implementation tool. So one, prevention. Management is goal should be early and quick management. We have already told that prevent PPH from becoming major decompensated. You have prevention, okay. You have done the management, but the management should not only be early and quick, it should be that you should see to it that she does not go into the decompensated stage, whatever treatment you do. Now coming to my topic per se, that is emotive trial. The early detection of the postpartum hemorrhage and use of the bundled treatment led to a lower risk of the primary outcome. The lower risk of the primary outcome of that PPH. And what is that primary outcome? Is it's a composite of severe postpartum hemorrhage, laparotomy for bleeding, or death from PPH. So these are the three things put together than the usual care among the patient having vaginal delivery. So the emotive trial says you should do the treatment in such a way that you lower the risk of this primary outcome. All the three, whatever I have mentioned. The emotive intervention resulted in a 60% lower risk of the primary outcome after the vaginal birth across the secondary level hospitals in all the African countries. And that is why Saswati Madam was telling that the emotive trial topic, what Sampath Madam has taken, is a very novel idea. So coming to the emotive trial, emotive bundle, in a nutshell, it is E stands for the early detection and trigger criteria. Then the M stands for massage of the uterus, what we do in our active management of labor. O stands for the oxytocic drugs, the entire panel of the drugs what we use. T is for the tranexamic acid. IV, that is at T, then IV stands for the IV fluids. E stands for examination and escalation. We are taking all these mnemonics one by one. So risk assessment tools, when we do this risk assessment, we always categorize the patients into three categories, that is low, medium, and the high risk categories. The list is there. I don't have to go into the detail because all of you know who are the low risk category patients, medium risk category, and high risk category patients. Just certain points on the high risk category, because we should be very careful about these patients, especially once they cross the second trimester, enter the third trimester, 33, 34 weeks. We have to be extremely careful about these patients. Who are those? They are those who had 2 or more medium risk factors. Active bleeding is more than bloody show. Remember, this patient comes to you saying that I have had active bleeding. It was, when you examined her, it was not just a simple kind of blood mixed with the mucus. Suspected placenta or accreta, however you have diagnosed this by sonography or MRI. Placenta previa, low-lying placenta already diagnosed, known coagulopathy, and history of more than one previous PPH. So these are all the anti-hematocrit values changing, and the platelet also showing less than 1 lakh value per millimeter cube. So these are the high-risk categories, and remember this, because you have to be doubly careful, doubly prepared yourself with the staff around. Keep the delivery in a decent hours, keep the blood bank alerted, get the blood bank, and so many things. So these are the high-risk category patients where you have to be extra careful. The clinical features to suspect the PPH. One, it is on the left side, we have put a column where it says findings in case of PPH, and for that, what would be the probable diagnosis? The relaxed flabby uterus after the delivery, it is atonic PPH. Anybody can tell all this diagnosis, very simple diagnosis. Contracted uterus, it's like a cricket ball, but patient is still bleeding when you check her. So maybe traumatic PPH somewhere below cervical tear or anything that can be there below, undelivered placenta or the partial expulsion. When you check the placenta, some cotyledons are not there. Those places are still, you feel there are empty places. That is ultimately it is incomplete delivery of the placenta. So it is a retained placenta or the placental cotyledons. Non-palpable fundus, definitely inversion of the uterus. You have to be extremely careful. This is one of the very important preventive measures when we do the controlled cord retraction to prevent the inversion of the uterus. Contracted uterus along with the absence of trauma or retained placental tissue, nothing is there. Uterus is but cricket ball. There is, you can feel that uterus. Then there is no trauma in the vagina. When you have checked, there is no tear, nothing. The placental tissues are also not there. So nothing is there, but ultimately what? It is a coagulation problem. It's a nightmare situation, that is DIC. Now coming to the quantification of blood loss, because in the very beginning we said don't underestimate the blood loss. So that means you have to estimate the blood loss properly, isn't it? So how do you do? By two important methods. One is the objective method, two is the subjective method. Objective methods, what are all those? One, gravimetric method, calibrated plastic sheet, use of artificial intelligence. Look, the artificial intelligence has crept into our labor rooms assessing the blood loss also. So the second thing is a subjective, that is a visual estimation of how much blood she has lost. So these are the two broad categories. Let me talk about the objective methods one by one. And first we will take the gravimetric method. The gravimetric method is an indirect measurement of the blood loss. Blood loss can be estimated by weighing. So it is the weighing those whichever absorbents we have put under her. So weighing those surgical material which are contaminated with blood and subtracting the dry weights. By summing up the measured weight of the blood and estimating the amount in ml, but it is unfortunately mixed liquid, like your maybe some fluid you have used for wash, the Savlon you've used, or the amniotic fluid, etc. So in the suction container, the blood loss can be calculated with the conversion of 1 gram is equal to 1 ml of blood. The factors of, so it's a very rough method. The factors of increased dilution by the amniotic fluid or rinsing lead to inaccuracy in the calculation, and this is what I was telling. So now coming to the second one, that is calibrated collector bag method. The collector bag is placed under the woman's buttocks immediately, like as we use the Kelly's pad, this bag is put under her. So immediately after the birth of the child, because you want all that amniotic fluid, everything to go, and you want that pure blood to collect there so that you will have a better estimation here. So after the birth of the child, and collects all the mixed liquid. At the bottom of the plastic foil, there is a calibrated collector bag, something like our Euro bag, with the scale on which the current blood loss can be read. It is easy to use, especially in resource poor areas, in combination with the visual estimate. So visual assessment plus use this bag method. So somewhere you will come to some kind of estimation of that. So this is what the bag we are saying. Better after all the amniotic fluid, urine, everything is gone, and you put this drape and you estimate the blood loss. Then coming to the artificial intelligence. How artificial intelligence is going to be intelligent here? So it is using the smartphone app. So what it does is calculates the blood loss by taking the photograph of the surgical gauze and canisters. It will look into the proper gauze about the density of the blood that is there, the color also. The colorimetric technique analyzes the photographic and geometric information from relevant areas, automatically filtering out the effects of non-blood component mixed in each sponge and canister. And what it does actually is it calculates the hemoglobin mass. So it is more calculating about the proper blood, and it tells that is what is in the gauze or the canister from the image. So it tells us how much of hemoglobin mass, which indirectly tells us about the blood loss. By entering the preoperative hemoglobin level, the blood loss can then be calculated. So that means how much she has lost, the difference. Now coming to the second, which I was mentioning, is the visual estimation. Peripartum blood loss is often not estimated correctly. I'm very sure all of you agree with me, because we will be handling many things at that time. The patient is not cooperating with us in labor. Sometimes you may have problem with the baby. The pediatrician has not arrived. So many things in your mind. Ultimately, how much you are going to estimate that visually, we are not very sure. The blood drain during the second stage of labor is often not measured. Absorbent material like the bed sheet or the drapes used to cover the mattress during delivery absorb some amount of blood, again, which is not estimated. And sometimes the clots may form. It's a good thing that clots are formed. There is no objective tool available which can assess the exact whole blood loss. We will, to a certain extent, tell you how to assess that depending on the appearance of the clot, etc. This is significant in cases of abruption, secondary PPH, where blood loss has to be inferred from the clots. This is rough visual estimation. On the left side, we have put the drapes, or what we call as the mops, what we use. So the first one in that is a lightly shaded is 25 ml, B is 50 ml, third is more intensified, more red, and that is 75, and the fourth is 100 ml, that is a complete discoloration into the red. The white mop has entirely turned into red, and that is 100 ml. This is a rough estimation. Then coming to the right, it is a clot. You are measuring the clot. In the left, you are measuring the blood as such. On the right picture, you are measuring the clot. So the size of a fist is equal to 50-gram clot. Probably we can tell this to our ayahs also, sisters, paramedical, etc. So they will be able to tell us. This patient is shifted to the ward. She passes one clot like this is equal to 50 gram. So this is what we have to tell her. Yeah, so this is again about the same thing in different absorbents, like the solid sanitary towel. If this much is shaded, it is 30 ml. Full kidney tray dish, it is the blood, that is 500 ml. Saturated means it cannot absorb anymore, completely absorbed. Small swab is 60 ml. Then below, saturated sanitary towel, the complete one she has used, that's 100 ml. The floor spill, etc. So this picture tells us about, again, the visual estimation of the blood loss, but we should have some idea. So that is why this picture, the probably that full kidney dish is equal to 500 ml is one which anybody can consider more accurately. So this is another proforma. This is which will be added into our case sheet in such kind of cases like PPH, where we have all the different columns to enter. Whatever we have mentioned previously, the same thing in the tabular column for our sisters or ourselves to enter. So now coming to the first, we have finished, that is the early detection, the estimation of the blood loss under that. Then second is the YUM, or it is the massage of the uterus. Now, in this PPH bundle, what we call as the active management of third stage of labor, or what we shortly call as AMTSL, the first thing, whatever you do is call for help. The help of another trained person will reduce your mental stress and improve your ability to work, and patient will get double the treatment. So under that, we have two things: the first response, and second one is response to the refractory PPH. The first response you do for all the PPH patients. If they respond, then you don't have to go to response to the second one, that is a refractory PPH. The second part, or response to the refractory PPH, is needed only for the refractory cases. So let us talk about this. Now, the uterine massage, the second YUM in that E motive. So the uterine massage is very, very important. When you do this after the birth of the baby and before delivery of the placenta for the expulsion of the placenta, or after the placenta has been delivered, also you massage the uterus, because you want the uterus to be kept in a contracted fashion. The first response PPH bundle must be implemented at both the primary healthcare and hospital level. It can be done by anybody, so it has to be implemented. Now, uterine massage, who can do it and how long to do? Skilled birth attendant, because they should know how to do the uterine massage, as we have shown in the picture. So the skilled attendants who are trained to do the same should do that. Immediate postpartum, every 15 minutes for the first 1 hour. Every 15 minutes, you do that rotating massage on the abdomen so that the uterus contracts. Then every 30 minutes after that, for the next hour. Now, how does this uterine massage help? It helps to encourage the uterus to continue to contract and prevent postpartum hemorrhage. Sometimes we have seen the uterus is contracted when you examine. After some time, few minutes, slowly it relaxes and becomes a flabby uterus. So we don't want that to happen. We want it to remain in a contracted tonic state. So after the placenta detaches and is delivered, the area where it was attached, the placental bed to the uterine wall bleeds, and that raw area is the reason. From there, the bleeding starts. When you do the uterine massage, what happens? We have studied in our MBBS days in our physiology books that the uterine musculature is in a crisscross fashion. When the muscles get activated, the blood vessels which are trapped in between these crisscross muscular myometrial smooth muscles will automatically get kinked, and that is how the bleeding stops. It helps in improving the tonicity and its maintenance. So I have finished the second one, that is a massage of the uterus. I'm coming to the third one, or the oxytocin drugs. So we have an entire list of the drugs, not going into each one of them in detail because each one is a separate topic. The oxytocin is separate. The misoprostol, the latest one, what we have been latest is for a few years we have been using the carbetocin is different. So there are a lot of drugs here. The main thing what we use is one is oxytocin, two is the misoprostol, third is the carbetocin. Carbetocin has the advantage that it can be given in asthmatic patient, it can be given in IM or IV, whereas the prostaglandin, that is prostaglandin, we have to give in IM, and patient cannot be asthmatic in case of prostaglandin. And third advantage of carbetocin is you do not have to maintain it in refrigeration, unlike oxytocin or the prostaglandin, because our sisters may not be so much trained. After the delivery, they may leave that emergency cart, the box then and there, and they may not refrigerate it, which is okay with carbetocin, unlike the oxytocin. So there are many drugs which we use. So that misoprostol is first by the trained community health worker and lay health worker. Anybody can use. So as I have told, the cold chain transport is not necessary in carbetocin, but very much necessary in oxytocin. And oxytocin can be given both as IM in the very beginning, as we give within 10 minutes, and then in a drip fashion. Whereas carbetocin is usually given as a prophylactic one, that is soon after the delivery of the baby, before the delivery of the placenta. So here the uterotonics, that's the oxytocin, is a part of the first response. So we are talking about the first response only still. So these are all the different drugs. Out of that, we have mentioned the oxytocin. Now coming to the T, or the tranexamic acid. So this is the fourth one we are talking about. So tranexamic acid reduces the death due to bleeding in women with PPH to an extent of 20 to 30%, and that's a great contribution, and we thank this wonder molecule. It is not associated with an increase in the adverse effects because we have been using in our practice so regularly. Reduces the incidence of laparotomy to control the bleeding by 36%, but certain studies have shown that ultimately it did not reduce the hysterectomy rates. FIGO recommends the administration of tranexamic acid as soon as the diagnosis of PPH is made, or even sometimes when you have the doubt, because your estimation of blood loss may not be proper. So as long as this is within 3 hours postpartum. So the dose would be 1 gram intravenous, run it over 10 minutes, and it has to be given regardless of the cause of PPH. It helps for traumatic PPH also. So if bleeding continues after half an hour or stops and restarts within 24 hours, in both the cases, then a second dose of 1 gram may be given. So it is 1 gram you have to give. So now coming to the IV, that is the IV fluids. So IV fluids, it is very much necessary. All of us know that this picture shows what you do in the arm side. That is the patient's hand, what you do, the head end, what you do, and the perineum. So 3 categories, like you have called the multiple people, the different people have come to your labor room or OT. Each one should be assigned their work. You have to make categorized. All people cannot come to the arm end. All people cannot work at the head end. So this picture tells us what the category, 3 different categories, and what that person can do. One, standing at the perineum, so call for help, massage the uterus, coordinate with the helpers, so catheterize the bladder. So it's like that. So this is one picture. in the nutshell, which tells what each person should do. Coming to the IV fluids proper, this is if it's a different gauge. All we know that's a 20 gauge, 18 gauge, which is known by colors, 18 gauge, 16, 14 gauge, etc. 20 gauge is a narrow one, so it is only 65 ml per minute, whereas 14 gauge will run 300 ml per minute. Suppose it is using the flow with the rapid infuser, it can enhance the flow to the extent of 500 ml per minute, sometimes which may be really needed for us. So PPH emergency response, the checklist would be the first response bundle. This is what I was telling all this while, is the kit should have the gloves, the tourniquet, because you will really not get the veins sometimes, that they are all flat, the cleansing wipes, the IV cannula, IV tubings, the connector, small things we may forget, and that may really delay by next 10 minutes. The saline, the ringalactate, the syringes, the oxytocin, tranexamic acid, misoprostol, etc. So this is for the first response bundle. Suppose it is not helping, as I had shown in one picture previously, then in spite of all the measures you have done, which I explained so far, like tranexamic acid, misoprostol, everything you have done, in spite of that, the PPH continues, unfortunately, she continues to bleed, or maybe that it has stopped for some time, but it again starts after a few minutes. So in those cases, you have to use these kind of interventions. And what are those interventions? One is a uterine balloon tamponade, and second is anti-shock garment that we call as a NASG. So this here, what we say is the E, that is the examination and escalation. That is the last component. You have to look extra in these pages. You have done everything, but there are certain tips you might have forgotten, and that is why these mnemonics are put. What we have extra things we have to think is evacuate the bladder. We know that bladder has to be empty so that the uterus will become intrapelvic and it gets contracted. It contracts. The evacuate the clots, the examine the genital tract. So all these are E to check for all the different things. Examine the genital tract to rule out the vaginal cervical tear. You may be thinking all the time about the tonicity of the uterus. You might have forgotten about the vaginal cervical tear extending up to the broad ligament also sometimes. Examine the placenta. Make sure the placenta is complete. Who knows? There may be a small cotyledon left inside. The os is open. Put your hand right inside and remove that. And fortunately, everything will settle. The uterus will contract nicely. Once that placental bit comes outside, this is the experience of all of us. So response to the refractory PPH. So what are you going to do? Additional things other than what we have explained so far is the aortic compression or the bimanual uterine compression, intrauterine balloon, what we have already told about this, intrauterine balloon tamponade, non-pneumatic anti-shock garment, a continued dose of uterotonics, whatever you want, and the second dose of tranexamic acid. Coming to the aortic compression, concept is to maintain the blood flow to the vital organs while preventing the blood flow to the inferior portion of the body, so thus keeping the vital organs well perfused. Operator stands on the right side of the patient, places the left fist on the superior left side of the patient's umbilicus, that is where you are going to compress the aorta while simultaneously palpating the femoral pulses with the right hand, and absence of the femoral pulse confirms adequate compression. This is only for certain few seconds you can do. The tamponade, this is the next one, is a diagnostic and therapeutic tool, both, because diagnostic, because it will tell you the PPH is continuing, as well as it is therapeutic because it is going to block all those raw surfaces. It should be considered early when emergency measures for the management of PPH are initiated after ruling out a uterus tear, and performed by trained and competent healthcare provider, because you are putting it right inside the uterus. It has proven to be an effective non-surgical technique. So the uterine balloon devices can be divided into fixed volume devices or the free flow devices. There are many devices like Bakri balloon, Rush balloon, etc. There are so many devices. Then coming to the non-pneumatic anti-shock garment, we feel that it should be kept in every place where the delivery is conducted, irrespective of the size of the caliber of the hospital. because it's a low technology, affordable first aid compression device for the management and stabilization of women with hypovolemic shock, because we want the blood to be rushing from the legs, the peripheries to the center. So it is in a hypovolemic shock due to the PPH and management of the refractory PPH. This can be, if trained, this can be used by even our sisters and ayahs to drape the patient with NASG garment, and that is of great help and a timely help. Temporary measure to maintain the hemodynamic stability to allow other definite interventions like transferring the patient in the ambulance to the other hospital till you arrange the blood, till the OT is ready for the surgery. So it buys time and keeps the patient in a better shape so that the hypovolemic shock is prevented. So this is the advantage of the non-pneumatic anti-shock garment, which reverses the shock when other methods have failed. So on the right side, we have put the picture. You see the numbers. All of us are familiar with this. You should 1, 2, 3, 4, and the fifth one has a ball which compresses on the uterus so that it keeps the uterus compressed. So that is 5. So we should train ourselves in draping the patient as well as undraping the patient using the NASG. It is lightweight, lower body compression device comprising 6 articulated pieces. It has drapes and hook and loop fastener segments that provide lower body circumferential counter pressure. It is a circumferential counter pressure to improve the cardiac output because the blood is diverted towards the vital organs. Apply NASG starting at the ankles and to remain in place until source of the bleeding is found, until patient is much better, until the patient is in proper hand, until you do something, it has to be kept. And bleeding decreases 25 to 50 ml per hour, and that's a great contribution from this NASG. 20 to 40 millimeter hemoglobin, mercury pressure applied, it increases the cardiac output and improves the central circulation, allowing an increased distribution of blood flow to the vital organs, as I have already mentioned. I'm in last few slides, and these are the ones where there are interventions or the laparotomies are necessary, and we are not talking in detail because this is not part of the emotive, like the uterine artery embolization, compression sutures on the uterus, what we use, B-Lynch, Hayman, etc., uterine artery ligation, iliac artery ligation, and the last resort one can think of to save the patient is hysterectomy. So these are all the different interventions one can think of. When you use the blood and blood product, timing is very, very important. You should procure the blood very, very early. As I have mentioned, categorize the patient, low risk, medium risk, high risk, so that you will be prepared. You will know when to keep the blood ready. Underestimation of the blood loss can happen and can be a very serious mistake, though we don't pay much attention certain times. Massive transfusion protocol one should be beware of. Optimum blood replacement would be, it's always a multi-component therapy like PRBC, FFP, and platelet are applied in a ratio of 1:1:1. There are other methods also like the SR cannula, vacuum suction cannula systems can be used, like what Dr. Vasudev Panikkar uses, etc., and can be used and has been tried successfully for atonic PPH.
Sorry, Rekha ma'am, to
Finish. This is the last slide.
okay, thank you.
Yeah. After insertion of the cannula into the uterine cavity, the negative pressure is applied. It has the fenestrations, but only thing that it can catch some raw tissue inside the uterine cavity or the cervical tissue, and it can get blocked also. So this is my last slide. The take-home message would be emotive is early detection of the PPH and treatment using emotive is from WHO. So using the WHO first response bundle, one has to be really knowing what is emotive and has to be used in the PPH cases right from the prediction till treatment, which will save the patient to a very large extent. Use of the calibrated drape for detection of the blood loss, then bundle of treatment, which we have mentioned, uterine massage, oxytocin, tranexamic acid, escalation of the treatment if refractory. Don't remain in the primary treatment. Step up your treatment. 60% reduction in the severe PPH is a great help to that woman and her family. The median blood loss, the need for the postpartum blood transfusion, and the number of maternals or deaths all are reduced because of emotive. And this is that emotive bundle what we are mentioning. Thank you so much again, Dr. Sampath Kumari Madam, for helping me. And with this, I close my presentation, and with folded hands, I request all of you that the presidents and secretaries of the societies to vote for me, that I'm standing for the chairperson of medical disorders in pregnancy. That is in the coming election. The election is in August, the FOXY chairperson election. Thank you. And thank you one and all. I close my presentation here.
Thank you. Thank you very much, Rekha ma'am. That was a very wonderful, elaborate presentation, and included all the whole of the PPH management, and we will follow the E-motive. And it is always the underestimation that leads to the death, actually, underestimation of blood loss after PPH. So during a PPH, we can always overestimate, but we should never underestimate. And as Madam said, if we use the correct, all the steps, the E-motive steps, call for help and have 2 or more people, at least 5 people should be there. And all of them we should always practice using drills, and that helps us to meet the situation smoothly. And thank you, ma'am. Thank you. It's becoming
Thank you so much.
Thank you, ma'am. We'll proceed to the next session by Dr. Ramani, ma'am.
Madam, namaste, Ramani Madam.
Good evening,
Welcome,
Rekha. All the best.
Thank you, ma'am.
And your talk was simply very simple, at the same time very informative. Congrats.
All slides by Sampath Madam.
Okay.
Thank you, ma'am.
Sampath.
Sampath ma'am, I think she's gone.
Irka madam. Good evening,
Okay,
Ramani madam.
okay.
Welcome. Welcome, Ramani madam.
Thank you. Hope you are in Delhi.
Yes.
Yes.
So the next session is the panel discussion on PPH case scenarios. And our moderator is Dr. Ramani ma'am, past president of FOXY, Sahiti. Okay. Ramani ma'am is our president TNFOG 2024 and national vice president of FOXY 2020. And ICO, she was the ICOG governing council member 2018 to 20.
Leave it.
As Madam said earlier, Ramani ma'am will mesmerize us with her case discussions, presentations. It's a great teacher. Welcome, ma'am. And ma'am, I would like to invite you to introduce Dr. Panchan Das, ma'am. Who is
So,
an expert.
Radhika, நீயே சொல்லிடு. எல்லாரையும் மேடம் பேனல் வரட்டும். நீ டைரக்டா எல்லாரையும்.
Okay, but Dr. Panchan Das, ma'am, Das sir is the president of Guwahati Ops and Gynae Society. And we have the panelist, Dr. Saroj Agarwal, who is a private practitioner in Agarwal Nursing Home Hospital. And she has huge working experience of more than 35 years. And she's the president of IMA Ludhiana 2021 and president of Ludhiana Ops and Gynae Society 2015 to 19. She's a speaker and chairperson in ACOG regularly since 2009. And areas of interest are vaginal surgery, high-risk obstetrics. Welcome, ma'am. And I welcome Dr. C. Suhasini Karnal, who is a consultant obstetrician, gynecologist, and laparoscopic surgeon, also an assistant professor in Sri Muthukumaran Medical College. And she's done her UG and UG in Chengalpet Medical College and PG in CSI Rainey Hospital. She's a FOXY member and she's a regular speaker in all TNFOG conferences and life member of IMA Tambaram. And welcome, Dr. Suhasini. And I welcome Dr. Swati, who is an assistant professor in Muthukumaran Medical College. Dr. Rashmi Ranjan Raut, sir, I welcome you. And Dr. Sharmila Pradhan. Welcome all the panelists for this session. And let's get into the session now. Dive into the session. Thank you. Thank you, ma'am.
I will share my PPT now. Hope my PPT is seen.
Yes, ma'am.
Yeah, first
Yes,
of
ma'am.
all, I should thank Dr. Sampath Kumari for giving me this opportunity, and as well as because she told me that only yesterday that I should do a panel. So I had to get some of the slides from Dr. Sheila Mane and Dr. Vidya Dupi in this moderating a panel on this particular topic.
Very sorry, madam.
Obstetricians and blood loss are closely related. We know every obstetrician would have had this occasion that we would have been very much panicked and very much disturbed when we see massive postpartum hemorrhage. Then hemorrhage, but we need to understand one thing, that hemorrhage in pregnancy is different from other hemorrhages. Like hemorrhage because of accidents or hemorrhage because of during surgery, all those things. That is totally different from hemorrhage in a pregnancy because it is unpredictable during pregnancy. What we call as a low-risk pregnancy can become a high risk and develop postpartum hemorrhage. But very high-risk pregnancies, when we take proper precautions, we can land up very smoothly. So now let us start with the case number 1. All of us are familiar with the 4 T's. That is stone, uterine atony, tissue, retained placenta, trauma, that is lacerations or injury to the vagina, cervix, and the uterus, and thrombin, that is coagulation dysfunction. So now coming to the first case, 26-year-old, she was an unbooked G3, P2, and L2 with the previous 2 full-term normal delivery. She was admitted in active labor at term. Delivered a healthy baby weighing 3.2 kg, and Amstel was done, and placenta was expelled after 10 minutes. So we think that it is a low-risk pregnancy where she has delivered immediately after coming to the hospital. But within the next few minutes, the nurse shouted, calling that there was a gush of blood from the vagina, and she had called for help. So immediately, like how we are trained, our team should be trained to manage any postpartum hemorrhage. She has given uterotonics, uterine massage was started, bimanual compression was done, and still the uterus remained flabby. See, note here, there was no IV line in situ as patient had come in active labor. So this is, I request my panelists, so the names may be different, but don't bother. Sugasini, can you comment on this slide?
She's a third gravida and she's come in active labor. We should have secured an IV line first of all.
Yes.
And then immediately when she notices a gush of bleeding, she calls for help. At least 3-4 persons should be called. And then start an IV line immediately. And then collect the blood and send for blood investigations. And then she should start her on oxytocin. And if she's not responding to oxytocin, we have to go to the next line of management, ma'am.
See, but here, see, any patient, also, third gravida can have postpartum hemorrhage. Not yes, that she previous normal delivery, third gravida can have. So, you have rightly pointed out that IV line should have been secured earlier. And always it is safe to collect a sample of blood as soon as the IV line was put up. Okay. Then how will you quantify the blood loss? The staff said that was a gush of blood. But I think Dr. Rekha had beautifully explained how we should quantify the blood loss.
Yes, ma'am. We have various methods to estimate the blood loss, ma'am. One is by visual inspection, like what we see and how much amount of blood comes, that we can do, or using the soaked pads or the collection devices, V-drapes and various kind of drapes from which we can know how much amount of bleeding is there. And then using the gauze, wet and dry gauzes, you can give a rough estimation, subtracting the wet weight minus the dry weight. Okay. And the actual amount of blood, ma'am.
You have again here in your comment, you have pointed out it is only a rough estimate.
Yes,
I agree to that, because whatever be the blood loss we see during labor, it is only underestimated. We do not know, actually it may be much more than that. So here weight plus measurement is equal to the total blood loss. Now, she found out that before delivery, there was only 100 ml of blood in the drape, including the amniotic fluid, patient's urine, and little amount of blood. But now, after delivery, the total volume of the drape was 700 ml, and the dry weight of the 5 mops was 10 grams, 100 grams, and 10 mops were used. So the final weight of the mops were 575. So together, what should be the blood loss? It should be weight of the mop 575 and minus the dry weight. That will be 135 grams is equivalent to 375 grams equivalent to 375 ml. And the total volume in the drape is around 700 ml. So before delivery, it is 100 ml. So she would have lost a blood of around 600 plus 375. It is almost equivalent to 975 ml. This is still only a rough estimate, and we can anticipate even much more. Maybe another 200 to 300 ml, maybe extra. So now what should be done immediately? Dr. Ojaswini, can you, Ojaswini or Dr. Saroj, whoever is the participant? Panelists.
Simultaneously, we can start an IV fluids along with the oxytocics to be continued, ma'am. If at all it is not controlled after that, also simultaneously do the massaging of the uterus, evaluate the any trauma happened in the genital area. And if at all it is not there, we can go ahead with giving carboprost injection, ma'am. In the meantime, vitals all to be monitored to assess the blood loss. If at all this heart rate divided with systolic blood pressure is shock index, and if it raises, if tachycardia and hypertension is there, we should immediately intervene and do massive transfusion also if needed.
So it should be a teamwork. Like she had shown the last one, few people at the head end, few at the perineal end, and two towards the sides. So there, the people who are standing in the side should start the IV line, and IV line, we should start a wide bore needle. Probably two things can be, IV lines can be secured. Oxygen ABCD. That is, oxygen should be kept to the patient. Immediately BP should be monitored. BP monitoring and pulse rate and oxygen saturation should be done. And you have rightly pointed out, the shock index is a very easy thing to calculate. That is the pulse rate divided by the systolic BP. Now, always we expect the systolic BP to be higher than the pulse rate. But when the patient is in hypovolemia, the pulse rate becomes much higher. So you have started 20 units of oxytocin. Okay. She has not settled. Now you are adding injection carboprost 250 grams IM. So before that, any simple thing the patient can be instructed to take.
Mesoprost.
Mesoprost can be taken sublingually, or you can just keep it rectally.
Rectally also we can.
Yeah, how much, what should be the dose of mesoprost?
600 micrograms.
600 to 800 micrograms, you can keep it. So this, I think we have discussed. Shock index is very useful because normal value of shock index, what is the normal value of shock index?
0.5 to 0.7.
0.5 to 0.7. But when the pulse rate is very high because of severe hypovolemia, and when there is low BP, then the pulse shock index goes high, as in this particular patient. So this is a simple thing to say that normal range is 0.5 to 0.7, and it has got a very good sensitivity and specificity of 51.2. And this can predict, based upon the shock index, we can predict what should be the, whether the patient needs a massive transfusion protocol, or whether she can be given 1 or 2 pints, and all the pints of blood, all those things can be assessed. So, okay, coming to this is the clinical stages of hemorrhagic shock. Can anyone say which is a stage? There are, all of you know that there are 4 stages. Anybody can share, discuss about the very clinical stages of hemorrhagic shock.
Stage 1, where you have the blood loss is less than 15%, and the volume of blood loss is less than 750 ml, and the pulse rate is raised, but it is less than 100 per minute, and the respiratory rate is also increased, but less than 20, and blood pressure is normal, and patient is still conscious but slightly anxious state. She's not gone into shock yet. And stage 2 is between 15 to 30% of blood volume loss, and 750 ml to 1500 ml blood loss. And the pulse rate has increased to more than 100 beats per minute. And the respiratory rate is increased 20 to 30. And the blood pressure is dropping down. She's gone in for hypotension, and mild anxiety is still persisting. Stage 3, where the patient goes into confusion and lethargy, that is prior to the acute shock stage. Third, where the blood loss is more than 30% and less than 40%, and the volume of blood loss is less than 2000 ml, and the pulse rate is more than 120 beats per minute, and the respiratory rate is also increased to 30 to 40. And stage 4 is acute shock stage, where the patient loses more than 40% of the blood loss and more than 2000 ml of blood loss, and pulse rate is more than 140, and respiratory rate is more than 35.
Okay, so this will roughly give us an idea how much the patient, the rate, increase in the pulse rate, fall in the blood pressure, increase in the respiratory rate, will give us an idea she is in which stage of shock. Probably in stage 1, she can be managed without blood, because we generally say PPH is defined when the blood loss is more than
500 ml.
500 ml. So probably this can be compensated. So in stage 2, maybe we need to be more alert. But again, stage 3 and stage 4 are very critical things where we have to take extreme caution and properly manage. So this is a golden hour period. And what are the things? Say 1, 2, 3, 4. What should be done?
Yes.
First of
Ma'am,
all,
immediately the
hello?
team
Saroj
has to be.
madam, Saroj
Okay.
madam. Yes, tell
Yes,
me.
ma'am. And the team has to be alerted. 3-4 people called for help immediately. And of course, 2 big bore cannulas put in. On one side, you can do the fluid resuscitation. On the second, you start with the blood components. Immediately, depending on the amount of loss we have had, blood loss, we have to order PRBCs and also FFPs. And on one side, all the investigations should be sent. The basic ones, CBC, sugars, and viral markers, along with the PTI and INR, so that you know whether the patient is going into coagulopathies. And if the patient is in stage 4, even the to avoid DIC, the fibrinogen degradation products can also be sent. And of course, the patient catheterized, the oxygen mask put in, the facial oxygen given to the patient. And then one by one, we rule out all the things. Once we rule out whether the uterus is atonic or do the bimanual compression, do the massage, and if we know that it is tonic, and of course give oxytocin at the same time, then we go to the second step that, okay, if the uterus is contracted but it is still bleeding, is there some kind of laceration? Is there some kind of tissue damage? Remains of placenta inside? Start exploring from the outside. Any vaginal laceration, any perineal laceration, any cervical tear, and then anything remaining in the, or even sometimes the uterine inversion or the rupture, anything remaining inside the uterus, any tissue, bits of placenta, and even the membranes can
Yes.
have a.
So it should be done, resuscitation,
step.
investigation, and examination should be done parallelly. The person, a
Parallel.
senior consultant who is at the
Yes.
perineal end, should patient
Yes.
placed in lithotomy, and she should first of all evacuate all the clots. Then you have a good visualization with a bright light in the OT. See whether there is any vaginal tear, followed by you see whether there is any cervical tear is there. And then you put the hands inside the uterine cavity to see whether there is any retained bed. That is very, very important. The patient, the person who delivers the placenta should always be very clear that the placenta should be complete. As you have rightly pointed out, even a small bit of membrane can cause postpartum hemorrhage. So having defined, if it is going to be uterine atonic PPH, what should be the management? Next participant. Next participant, Dr. Sharmila.
Hello, yes, ma'am.
Yes.
When this is PPH is confirmed, that you have to keep or anticipate regarding first of all, we classified the low risk pregnancy or high risk pregnancy, or where the risk is there. But everywhere the PPH box should be kept ready, because at the golden hour you should have prepared for all those things by your hand and in the labor room itself. So this box should be kept ready before anticipating the PPH.
So every labor room should possess a
Yes.
postpartum hemorrhage box,
Yes.
which should
Yes.
be checked every day by the senior staff who is in
Staff
charge
nurse.
of the labor ward, and then see to that all the ampules are they are not past dated. We have to have
Expired
a clear thing.
or not, or
Expiry date should
all
be made.
everything is checked. Yes, ma'am.
Yes. Then Rekha madam has clearly shown that tranexamic acid is going to be of much use. Can anyone elaborate how should tranexamic acid be given and when should it be given?
Ma'am, tranexamic acid. Okay.
Yes. Go ahead.
Tranexamic acid can be given as soon as possible, ma'am, because even it is a trauma, it will be helpful because fibrinolytic activity will be maximum during the initial stages of the PPH. So the action would be appropriate when we give within 3 hours at least. And 1 gram of tranexamic acid in 100 ml can be given almost 15 to 20 minutes, and we can wait for the response. And if it is that action will last for at least 7 to 8 hours. And if needed, the bleeding is stopped and again restarting also, we can repeat the second dose after 30 minutes if needed, ma'am.
Yes. So tranexamic acid is an ideal one as it has a markedly enhanced fibrinolytic activity and fibrinogen depletion are common in early stages of bleeding. So this can be being an anti-fibrinolytic agent. This can help in prevention of postpartum hemorrhage by forming clots. So if bleeding persists after 30 minutes, second dose can be given. So then duration of how early tranexamic acid should be given? What is the maximum duration from the onset of the event to the first dose of tranexamic acid? Beyond which it doesn't help.
It should be given within 3 hours, ma'am.
3 hours, yes. So when the person who is in charge of giving medication, first thing is starting an IV line, putting 20 units of oxytocin, sublingual misoprost or rectal misoprost. Then you can give prostaglandin. 250 micrograms can be given. And immediately through the second line, we can start giving tranexamic acid. At the same time, you have to have a sample blood taken for blood and blood products. Okay, so this was one trial was done in 2017 where they found out by giving tranexamic acid much earlier, that is lesser than 3 hours, it reduces the death due to postpartum hemorrhage by 19% and death due to bleeding was reduced by 31% when treatment was initiated within 3 hours. So that is why they say they are very particular, it should be given as early as possible. In contrast, the reduction was not significant when the time interval has crossed 3 hours. Then it reduced the incidence of laparotomy to control bleeding by 30%. So unnecessary laparotomies for going ahead with an obstetric hysterectomy or beading sutures that can be avoided. And it did not reduce all-cause mortality, which included death from sepsis, organ failure, eclampsia, and pulmonary embolism. It can only reduce the death and morbidity and mortality only due to bleeding. And we should also understand that it did not increase the risk of thromboembolic episodes, which had been a concern based on the data of case reports. So formally, we thought that tranexamic acid is one agent which can increase the thromboembolic episode, but we know now that it will not. See, in patients who are having severe postpartum hemorrhage, given massive transfusion protocol, they are at high risk of developing thromboembolic episodes. So this tranexamic acid may not aggravate that. Okay. Then let us see what is WHO recommendation. So WHO also recommends the same thing, that it should be given 3 hours of the event and the patient having clinically diagnosed as PPH after vaginal delivery. And there have been studies. I don't know how many of you use prophylactically tranexamic acid while doing cesarean section. Anybody? No? Because now we have a lot of studies, especially the study was from AIMS, Delhi, where they found out that they had done a study comparing placebo with 1 gram of tranexamic acid. Just before the induction of anesthesia, they found out that there was a decrease in the blood loss of 125 ml. So probably the patient will be benefited by giving tranexamic acid, and regularly we are giving in our center. Tranexamic acid will be given prior to any C-section and likewise prior to any laparoscopic surgeries where we think like with dense adhesions or in adenomyomectomy or in endometriotic surgery, we always routinely give tranexamic acid. Okay, then what about anti-shock, non-pneumatic anti-shock garment? Will it be of useful in this situation? See, here still we do not know whether it is atonic PPH or this one. So probably taking into consideration, this is a case of atonic PPH. If the center doesn't have the facility for advanced management, will anti-shock garment be of any use?
Transportation process.
Definitely
Yes.
it will be of use.
Can anyone explain
Yes.
about the anti-shock garment? What
It has-
Rekha had already explained, it contains for both the legs,
It's
1, 2,
uh,
3,
starting
4.
from ankle to
Ah,
both the umbilicus, and you have a ball also in the fifth segment where it will
Ah.
compress the uterus. So it helps in contracting the uterus also, and
Ah.
it helps in supplying the blood to the vital organs from the leg towards the central part, so that patient will have time for it will buy time for us to give blood transfusion. And if in case a patient is there in the primary health center, a patient can be also shifted to a
Shifted to
tertiary
the
care center.
tertiary. Okay. So this is the non-pneumatic anti-shock garment, and about which you have explained. See, suppose if the patient is getting stabilized, if the bleeding is getting controlled, even without transporting her to the higher center, or after transporting to the higher center and investigating her for further causes for postpartum hemorrhage, how long you should retain this anti-shock garment?
At least 24 to 36 hours.
Yeah. See, slowly when you are removing, how should you remove it?
Again, from below upwards.
Below?
Starting from below, ma'am, below, and then slowly one by one you have to release
Yes.
and feel
You
for the
remove one
pulsation.
thing, wait for some time, see whether the pulse rate and the saturation and BP are maintained, then slowly you can
And
remove
slowly
the
remove the next
entire
one.
one. Okay. So, is there any way of controlling the postpartum hemorrhage?
Balloon tamponade also.
Balloon tamponade. What is anybody has got an experience in use of this uterine tamponade?
Madam, we sometimes use the Bakri balloon tamponade, but
Ah.
the most easy one is to make a simple one by using a condom, putting it over the Foley's catheter and then inflating it, and then putting it inside and using slightly warm saline or the ringer, and that helps in maintaining the pressure on the uterine walls, and it helps control the bleeding temporarily.
So this can be either in a patient who has delivered vaginally or in patients who are undergoing cesarean section, especially for placenta previa or abruption. All these patients can be prophylactically. You can use any one of this balloon tamponade. I should share, I had a very bitter experience when I used this tamponade, because that was a case of placenta previa where I had put in a Foley's balloon tamponade. I was happy because immediately there was not much of bleeding. But after 2 hours, my staff called me telling that there is increase in the height. The height of the fundus has increased. So actually what has happened, the blood has seeped because the cervical outlet was tight. Whatever blood has collected, it has seeped into the myometrium, and the entire uterus had become aquilar, and then I had to redo that, and then she has to undergo hysterectomy. So when we have to advise the staff to have a follow-up over the fundus of the uterus. See whether it is in the same position or whether it is increasing. Okay, so this is all the proper placement. The entire balloon should be inside.
Yes.
And improper placement. And sometimes if the cervical canal is wide open, you can even do a circulage over the cervix, so that it will prevent the balloon from coming out. Okay, so anybody can share how far the uterine balloon tamponade is successful? Is it 100% successful?
Ma'am, we have used it only for the normal delivery sometimes in cesareans, because sometimes I find that twice or thrice I found the uterus very big, and once I feel that this will not be sufficient, so we have packed the uterus with the sterile.
So in normal
gauze.
deliveries,
And-
maybe to certain extent, only 80% to 85% it will be of use. Otherwise, we have to be very careful. Only the uterine balloon tamponade cannot prevent the postpartum hemorrhage. No.
Madam,
now
we can
we have-
use this for transportation also.
Yes,
If
yes,
you need
transportation,
from
of course.
transportation, you can use.
Yes, Yes,
Thank
along with the non-pneumatic anti-shock
Yes,
combat,
yes.
plus this uterine balloon tamponade, you can go for ship. But
Yes.
of late, how many of you have used the suction cannulas? Yes,
No,
sir,
ma'am.
cannula
We are
or
not very happy with
Manicus
the
cannula.
suction cannulas.
Ah.
So we know that people are using suction cannulas, but somehow I think that will suck some basic tissue also into the cannula. And so I'm not happy using the suction cannulas.
But I personally feel suction cannulas should be kept in the labor ward along with the forceps, because it is such an useful one that it will definitely, see the basic principle, all of you know that you put it and then you connect it to the vacuum. So by increasing the pressure of vacuum to 700 millimeters of mercury, all the walls of the uterus is compressed over the suction cannula. So I feel this is a very, very useful one. Maybe you can retain this for about half an hour and slowly you can reduce it once when the bleeding stops. Here again, I would like to share one of my patients who had been benefited, who was benefited by this suction cannula. That patient was initially for the previous pregnancy, which was, she was a primigravida, low risk, no high risk factors. She delivered and she had a massive PPH and it was on the era prior to carbitocin. So we had given 20-40 units of oxytocin. She did not respond. Of course, we got prostaglandin also. So she was shifted to the OT and she had undergone B-lane sutures along with internal iliac artery ligation. So the same patient, she came to me after 6 years with other pregnancy. Now, she becomes a previous history of PPH, previous history of collaterals being developed by the bilateral internal iliac ligation. So is she going to be a high-risk candidate for repeat PPH or not?
She is.
She is. So what will be the treatment modality you will plan in such case? Because already you can give, of course, now we have carbitocin. We can give carbitocin. And already bilateral ligation was done. And when I opened, it was showing multiple vascular channels because of the collaterals what has developed post-delivery. So what should we anticipate? So we should anticipate PPH. And then what should you plan for her? She says, I want to conserve my uterus.
And we should be ready for the uterine artery embolization in such a case if needed later on.
The uterine artery embolization, see, already it has developed so much of collateral. Where is the question of going in for uterine artery embolization?
So even the internal iliac artery ligation, bilateral internal iliac artery ligation.
Bilateral, I have already done a bilateral iliac artery ligation in the previous pregnancy.
So even the hysterectomy, then the final.
See, she is very keen. I don't want to have hysterectomy. That was the real situation I faced. Sir,
and some sutures,
expert opinion by Dr. Panchanan Das, sir. Can you give what can we do in this situation?
We'll have to see whether it develops PPH or not. If it develops, then I believe that things can be done easier. We need to give some compression sutures about the uterus.
Yes. So what I did was, see, the previous compression sutures were seen very prominently. This patient, I opted for SR cannula. As soon as the baby, I planned for an elective section for this patient. I told her when the abdomen is opened, I can go ahead with any procedure, whatever I want immediately. So I put in a suction cannula and then I maintained the pressure for 700. I waited for around 5 minutes before I closed the uterine cavity. To my surprise, the anteroposterior wall has beautifully compressed and the bleeding was, and we had given carbitocin, prostaglandin, misoprostol, everything, and oxytocin drip was flowing. So she did not have even a normal expected bleeding during what we expect during C-section, and she was very comfortable, and I had sutured the uterine cavity and came out, and this slowly I removed the suction cannula after a period of 4 hours, and she was very perfect, and she did not even require even a single unit of blood transfusion. So there are situations where uterine suction tamponade is of very much practically it is of much use in the current scenario. So these are the various types of this suction cannulas, where in a normal delivery, where the cervix is widened, we can have the breath can be larger, and in the C-sections, it can be a narrow one. Okay, now let us see what is the we learned something about carbitocin. How many of you use routine carbitocin during any C-section?
Used.
We are using this.
Yes.
Ma'am,
Many
somehow
of us,
we
I
have
think,
found
many of us, because we don't want the mother to lose the blood. So we electively, for all cases of C-section and emergency C-section also, we give, in our unit, we give carbitocin as well as tranexamic acid. So now anybody can share what is the advantage of carbitocin over oxytocin. I think all these things Dr. Rekha has mentioned, it is just for the pressure.
It can be used. First of all, the negative thing is cost is more, ma'am, but it is heat stable. There is no cold chain maintenance thing is not there for carbitocin. And also it is single dose regimen will be very effective. Prolonged duration of action is there. Multiple step up doses is not needed in this. And we can give us a slow IV also.
So then the other advantages are, it can reduce the number of, amount of blood loss, the need for blood transfusion is very much reduced. So there are so many advantages of using carbitocin. And I think the cost, when we compare to oxytocin, escalating dose and using multiple IV lines, all those things can be counteracted by a single dose of carbitocin. Okay, so the results, they have shown that group C is carbitocin, group O is oxytocin. There was no primary PPH when they have given it for prophylaxis in cases of high risk. Massive blood loss was not there. Immediate blood transfusion, no. Need for additional uterotonic. Only one dose of carbitocin was sufficient, and average blood loss was only 325 ml. So no significant differences regarding the side effects in both groups, and hence carbitocin may be considered much effective and rather a good alternative to oxytocin. Okay. And the Indian scenario, I hope all of you know about this champion trial, which was done in India. It was done across 23 centers in 10 countries, including India. Centers in India, some of the leading centers in India had been a part of it. Okay, so that showed that carbitocin proved to be non-inferior to oxytocin with ease of single dose administration, and it doesn't need any refrigeration. Okay, again, WHO also recommends that carbitocin should be the preferable one, even in settings of low resource settings. It is found to be, even though it has gotten slightly an increased additional cost, when you compare the other, if the patient develops postpartum hemorrhage, the cost and the stress we are going to undergo is not much when compared to the primary cost of the carbitocin. Okay. So in that particular patient, what were the things that has to be done? Come back to our original case. So somebody said already blood and blood products to be arranged, and condom catheter we have finished. Anti-shock garment applied. Patient was monitored next to 24 hours and general conditions stabilized gradually. So we had a positive outcome in this particular patient. So the learning points, what each one of you tell one single point in this particular case, which is very important to as far as the safety of this patient is concerned.
Being a multigravida, the IV cannulation securing is very important in the initial.
Yes. Then.
And teamwork is needed here, and appropriate time for calling for help for the early diagnosis of the atonic PPH to be needed. And also they should be technically, the assistants to be skilled enough to do simultaneous massage and also put a condom catheter. Stepwise management and monitoring should be recorded so that we can know the response time to time by monitoring their vitals.
Yeah, one person should be totally allocated to the series of events that are being monitored and drugs that are given, and then we have to have a good counseling with the patient. So now and then at least not a very senior person, one person should have a listening with the patient's attender what is happening inside. And now our policy is to have a attender by the side in the labor ward. And do you think that you can have a attender in the labor ward in this scenario?
I don't think so. It will be a
No.
disturbance for us.
No, yes. And that
May have a
they
negative
may be
impact.
panic. Yes, yes, ma'am.
Yes, because they will go and say the patient has bled so much. She had bled. Kodama kutichi, nobody bothered. Sir, I want you to give the final verdict for this patient, whether this patient has been properly managed or not.
Das, sir. Are you not there?
Yes, sir. Yes.
Yes, madam. I am very much here.
Okay, sir. You give your final verdict for this.
But what I feel is we are not using methyl ergometrin in this situation. Why? We could have used somewhere because she is not hypertensive. Otherwise, she was managed well.
Yes, sir. But I think methyl ergometrin, how many of the labor rooms they have methyl ergometrin in the box?
Still, methyl ergometrin is the best drug for atrial contraction, retraction. I think.
I agree.
Yes, sir, you are right. We have, sir. We have in the PPA box, ma'am.
Then one more thing was
if you believe me, what I do is while doing cesarean section, if any moment I get that this patient is bleeding, what I do is I always give syntocinon and metharzine mixed together in one syringe. In 2 ml syringe, I just inject intramuscularly.
Sir, formerly there was one preparation called a symptometrin.
Yes, agreed.
That was available.
Yes.
It was
So
there.
when I started my practice, we used to have it, and we used to give it as it was given very simply IM. Just soon after the delivery of the placenta.
Yes.
Madam, we still use methyl ergometrin IV immediately after the delivery of. We use a single ampule of methyl ergometrin, methargine, IV immediately after the delivery of placenta.
Yes.
But madam, we have seen many cases who start vomiting after giving.
We are not giving routinely, ma'am.
We used to get prostaglandin also gives vomiting. So we always, it is a practice to give combined, as soon as we give prostaglandin or methagen, we have to give emisset, ondansetron to be given to avoid vomiting. Okay. So shall we move on to the next case? But thank you for your valuable input, sir. Still in the event of postpartum hemorrhage, methyl ergometrin still has a role in the absence of, probably when these patients are in the having bleeding, the blood pressure is not going to be hypertensive. They are going to be hypotensive. So I don't think it is given. Probably only exception in any situation is a cardiac condition. Okay. So we'll move on to the next case. This is on a busy night. A primary gravida delivered 3.5 kg baby with an episiotomy. Since there was another delivery, the junior assistant were asked to suture the episiotomy. But 2 hours later, there was a call from the labor ward that the patient is complaining of severe pain lower down and wanted to push badly. What is the situation? What is the likely situation?
It's a hematoma, ma'am. Vulval hematoma could be.
Yes, vulval hematoma is the most common thing. Why do you think it is probably a vulval hematoma? What are the points that are seen in this case scenario to say that the patient is likely to have a vulvovaginal injury? See,
first of all, yes, ma'am. First of all, the baby size is bigger, 3.5 kg. And there must be some laceration extra apart from the episiotomy. And the junior resident may not be that much skilled to suture the properly.
Yes.
So I may anticipate.
There may not be any big baby, primary gravida, and she would not have been properly sutured the episiotomy site. And the chances for laceration is quite high in this situation. Okay, so this was what was seen. And always one thing is, when a patient feels like pushing something or having a sensation of defecation post-delivery, always rule out vulval hematoma, because the vulval hematoma may not be seen externally, but it may be behind in the ischiorectal fossa, or it may go ascendum. on the pararectal region. So whenever a patient complains of severe pain or defecation sensation postnatally after within few hours, you have to think about vulval hematoma. Having seen this hematoma, do you think that it can cause postpartum hemorrhage?
Yes.
Yes, ma'am.
Because in the postpartum hemorrhage, there is no definition whether it is atonic or traumatic. So
Yes,
we are very sure that such a huge amount of hematoma, it can have a lot of blood loss could have been there. So what are Swati, you see this in your labor room when you are
Yes.
on duty. What are you going to do?
Immediately, we should make an incision in the dominant site, evacuate the clots completely, and
You want to do it in the labor room itself or shifted to
we
the
should
OT?
shift her to OT.
So that is
Yes.
very important.
Arrange blood
Get
and blood
another
products.
line, shift
With
her, get
yes.
the
Arrange
blood
for
and
blood
blood
and blood
products.
products.
Send somebody for blood products.
Yes,
Okay.
ma'am.
Okay.
She
So
will be needing the transfusion immediately also.
yes, yes. See, why do you think? See, madam has already said the cause for vulval hematoma in this particular patient is a big baby. Apart from the big baby, or even a multiparous woman, we can get the vulval hematomas because of the varicosities that are found in the vagina and the vulva. And which sort of episiotomy causes more of vulval hematomas? Midline or a mediolateral?
Mediolateral, ma'am.
What, pardon?
Mediolateral, madam.
Mediolateral will cause more of vulval hematoma because midline incision, the patient will go only for complete perineal tear. There won't be any hematoma formation. Okay, so this patient, as you have rightly pointed out, you have shifted the patient to the OT, evacuated the clots. Will it be easy to catch the bleeder as you have mentioned?
No, it will not be.
Not, not always, ma'am.
It will not be so easy. Remove the clots, give a good saline lavage, and then if you can see the artery, you catch it. Otherwise, what you should do? Put
We
it
should-
layer. Suturing should be done in layer. And would you like to have a primary closure or would you like to leave a drain in that?
Better
Drain.
drain.
Better to keep drain.
Better to keep a drain.
A drain should be given, ma'am.
Pardon?
Yes. If the bleeder is identified, then the drain may not needed. But
Yes.
if
But
you
if
will
you are
not get any
able to
bleeder, only
see,
laceration is there,
so in such big
Yes, yes.
hematomas,
then drain should be given.
yeah, in such big hematomas, definitely you need to keep a drain, or sometimes you catch the bleeders, tie
Yes, ma'am.
as early as possible, and then pack it out and pack up the hematoma site and then come out. Okay, because if you are going to put the sutures also, it will tear. It because of the softened mucosal tissue and the skin, it will tear. So better to keep
It is
some
friable,
tight
friable also, ma'am.
pack and then come out with the drain. Okay. So if
Yes.
suppose if this we have discussed, suppose if the hematoma is found to be what is the apex of the hematoma or whatever it is, if you are able to see it fully, it is okay. Sometimes what happens is the hematoma can extend into the broad ligament. So what are the signs to say
Broad
that
ligament.
it has extended into the broad ligament?
Hemodynamically unstable.
Yeah, the patient will immediately become hemodynamically unstable. Okay. And another one important finding is if you palpate the uterus will be found shifted to one side
Shifted,
because of
yes,
the
one
huge
side.
hematoma. Okay. So then immediately clinically we can suspect hematoma and then you can confirm it with ultrasound. Okay. Then what are you going to do? You are going to observe or you are going to take a laparotomy.
If it is a small clot, then we can observe, ma'am. Otherwise, we have to go for a
Otherwise,
lab.
it is always anything. When the clot is less than 5 centimeters, they say that we can leave it. And I have seen sometimes one long time back, I had a patient who had a big hematoma, 10 centimeters. She delivered 3 days back and she was referred to me just for the sake of the baby, neonatal care. But when I examined the mother, she was found to be very pale. And when I clinically examined her, she had a huge broad ligament hematoma, but that was settling on its own. I just corrected her hemodynamic stability. I had brought her out by giving blood transfusion. and it regressed, but it took a long time. Under cover of good antibiotics, we can prevent things. So because sometimes by doing the laparotomy and opening the broad ligament hematoma, what are the adverse things you will face?
There's a chance to injure the ureters.
Ureteric injury.
Ureteric injury is very common, and then sometimes you may not be able to control the bleeding, and you have to finally land up with a hysterectomy. Okay, so timely presence of thinking, and you have to have a idea.
But we have to monitor the size of the broad ligament hematoma. Is it growing or stable or decreasing?
Of course, we have to monitor the size.
Yes.
And monitor her daily, morning and evening, her hematocrit. See whether it is falling. So falling hematocrit suggests that the blood is getting collected. Or if you give continuous blood transfusion and if it becomes stable, then maybe she needs follow-up. Okay, so this is what is given in this slide. And something, okay. Now you know the atonic PPH or traumatic PPH. Sometimes it's happening in a primary health center level. What are you going to do there?
The same way we can secure a IV line, and also we should gain time, ma'am. Initially, we can give a uterine massage and compression can be given.
Yes. So compression, proper compression will definitely help to prevent. It will act as a tamponade. See, I remember one of my professors, I don't know how many of you know about Dr. P.N. Kantamani, who passed away recently. She was a retired director of Institute of Obstetric and Gynec, Egmore. She used to say, if you don't have anything, you just put in a sterile, washed sari inside the uterus.
Yes, ma'am.
It will stop. It will definitely stop. So we have to act according to the timely situation. So now, packing is one sort, and opening and closure, everything they have done. Now, suppose she has an atonic PPH, and do you have anything instead of going in for a laparotomy? Of course, after all, you need only some few hours of time for clamping the uterine artery. Can we do it without doing a laparotomy?
Vaginally, we can clamp.
Yes.
We have
But how can you do the vaginal clamping?
We have specialized clamps for that, ma'am.
Who has noticed that?
This
I forgot the name.
right.
Yes? You can never forget Paley.
Butterfly. Okay.
Paley-Sars clamp. You can just put it. See, I will show you here. So this is what Paley-Sars will show. You can pull the cervix and apply the clamp so that you know that the uterine artery is coming and turning upwards at the cervico-uterine junction. So you can catch it. And there is one more thing by Dr. Ramalingappa, where he says the same thing. He keeps that thing laterally, puts a clamp, and then you can, after all, we can do whether there is uterine artery is clamped well or not by using a Doppler. We can confirm, isn't it? It's very simple. Any labor ward or any institution is having now ultrasound is provided, and we can help do that. So then I think this PPH tray should contain, don't get panic when you see a case of postpartum hemorrhage. First is that, think for a minute, what are the things you should do? First thing is, when she delivers, when one group is resuscitating in the upper end, you bring her to the lithotomy, see whether the episiotomy site is extended, and see, catch immediately the cervical thing, see whether the cervix is intact. Suppose if you see a cervical tear, you can apply this sponge holding and make the bleeding arrest, and relaxedly you can take the sutures. So you need to have a ribbon pads, needle holders, scissors, sterile pads, sutures, and of course condoms if you feel that it is a atonic PPH. So, so these are the points to be remembered. First thing is, Amstel will help in controlling only the atonic PPH and not a traumatic PPH. Similarly, uterotonics will help to control only atonic. But you should understand that tranexamic acid will control both atonic as well as traumatic PPH. Okay. And most often, not a single component is there. The patient will have both atonic as well as traumatic PPH. Okay. So, Radhika, can we move on to the third case, or you want to stop with this?
Yes,
Because
ma'am,
Yes,
we
I
can
should stop it.
we can. Okay. So case 3 is Sonia, 33 years, G3P1 L1 was referred due to abnormal presentation diagnosed during ultrasound at 26 weeks. She had previous LSCS with for CPD. Transabdominal sonography showed a viable fetus with an appropriate biometry, normal amniotic fluid, while transvaginal Doppler images suggested the diagnosis of placenta previa accreta. So, how will you differentiate placenta previa from placenta previa accreta by ultrasound?
The vessels will be transversely passing from the endometrium to myometrial junction, and then the post-placental lacunae also will be there, ma'am.
Lacunae. There will be a lot of lacunae. And what about the space between the placenta and the myometrium? Will you be able to see the space?
The junction will not be there.
Junction will not be there. And when you do the transvaginal sonography, you can make the level of, because she is only 27 weeks. Okay, cervix would not have been taken up that time. So we can see the lower uterine segment and the placenta and the margin between the placenta and the myometrium. We can see that apart from the lacunae, there will be large areas of vasculature, which can be picked up by the Doppler. Okay, so this was here. See, you can see the bladder, you can see the cervix, and you can see the lacunae of the placenta, and you see lot of vessels. Are you able to see the distance between the myometrial separation and the placenta here?
No.
No. Then one more thing is, see here you see the bladder. Whether it is getting inside the bladder or not.
It's getting into the bladder.
Yeah, we don't have any space between. So probably this is a placenta accreta that is migrating itself into the bladder. Okay, so this patient, will she have spotting at the earliest stage, or will she not have any bleeding through the entire antenatal period?
She may not have bleeding spotting.
Will not have bleeding. That is because
it is
Unlike accreta. So it will, so when ordinary simple placenta previa, what happens is sometimes the patient will have intermittent bleeding. She will come and get admitted. Then we know that it's a case of placenta previa. We keep her for some time. Then she settles down. But these patients, they don't have features of any antepartum hemorrhage. Okay. So then now, and of course, all of us know that previous cesarean section delivery, the scar is the most favorite size for the placenta to implant and cause accreta. Okay. So this one we have discussed already. Then, do you want to do an MRI for all cases of placenta previa? Do you want to do?
Yes,
Not necessary. Not necessary. Only when you have a doubt, you can just a simple color Doppler with a detailed ultrasonogram by a senior radiologist or a person who is trained in obstetrician trained in this can pick up. Okay. So, but MRI may be of use when you are in doubt. Okay. So, in MRI, there will be a lower uterine bulging, heterogeneous placenta, dark interplacental linear bands, and it can also provide, one more thing is it can provide how much depth of invasion of the placenta accreta. Okay. And especially when you have a posterior placenta previa, where your ultrasound cannot reach the posterior myometrium, it can be of use. Otherwise, I think a detailed, very well done ultrasonogram can be of use. Now, when will you suspect bladder involvement? In this particular case, are you suspecting bladder involvement or not?
The ultrasound showed bladder involvement.
It may be, but the patient doesn't give any history of hematuria. Because you are likely to get intermittent hematuria in patient with the placenta accreta perforating inside the bladder wall. Okay. So how cystoscopy is not of use because usually the involvement will be in the wall of the bladder only. Okay, now everything is done. So she is planned for elective section. What are the precautions you will take, Swati?
First of all, we will arrange, see her blood grouping typing and arrange a blood for her and
Case should be done in a tertiary center first.
Tertiary center. You want to do it in a tertiary center?
Yes,
Sugashni,
ma'am.
I
All
suppose
centers
you are
for
in a medical college and it is already a tertiary care center. You cannot say
facility for
no.
uterine artery embolization also we should be ready to uterine artery embolization should be available, ma'am.
Okay, not
Urology.
always.
So that we can
Not
plan.
always. Okay,
Not
because
always, but
not
give a
all
better.
district headquarters are having facilities for uterine artery embolization.
Yes, ma'am.
Okay,
Agree.
so you need to have a good teamwork. See, like
Teamwork.
how Swati has
Blood.
mentioned, blood and blood products should be arranged. Then tell me one after other. Get a detailed consent. Tell her that her chances of massive transfusion protocol is needed. She has, sometimes she may need a hysterectomy. Isn't it? Then
Consent.
step-wise
Yes.
devascularization. And then bladder injury,
Injury.
ureteric injury. All those things you have to explain to them in detail. Okay. Now you have got the consent. You have got a good team. 2 IV lines, or if needed, maybe a central line can be there. And then you can have Foley's catheter should be inserted. Okay, because we need to know whether if you had opened the bladder,
Okay.
have it. And ureteric stents, I think just on opening, if you find the ureteric orifices, then usually the injury will be in the fundus, not at the level of the trigone. Okay. So all those things. Now where you are going to put all the drugs, suppose all drugs that are needed for making the uterus contract, everything is needed. And what sort of anesthesia you will prefer? What anesthesia?
General.
General anesthesia.
General anesthesia.
Yes.
General anesthesia will again further increase the bleeding. Rather
But
go with an epidural, spinal with an epidural. That will be of use. And we need to have a team, not only intraoperative care, postoperative care is very effective. And as somebody has said, if facility for catheterization, that will be good. And do you need to give thromboembolic prophylaxis? We have discussed in the first case itself, massive transfusion protocol or anything, any PPH, you need to have, once when the bleeding is settled, you need to have a thromboembolic prophylaxis along with infection prophylaxis. So, sepsis, we should anticipate and we should give a high dose of antibiotics. Okay, this is what we said. Anesthesia, preferably, I would rather prefer spinal analgesia with top up with an epidural. So, how can we reduce the blood loss? How will you go ahead with the surgery for this particular patient? See, today I have got one patient, central placenta previa with the transverse lie, previous Caesar. I have got her admitted, planned for surgery on 15th. So now mentally, I am going to have a workup from the words what you are going to tell me. Tell me what you're going to do.
Since
Arrange for blood. Okay.
blood loss will be more, we can operatively plan for stepwise devascularization, ma'am.
See, don't jump it in. What incision you will do? Madam, Sharmila, madam, what incision
Yes.
you will do?
We can give, will not go through the placenta. We'll give incision above that.
Yes. No, abdomen incision, will you go for a transverse?
Longitudinal
Always
is better.
a longitudinal RPM or a midline incision is
Yes.
very safe. And then you palpate the placenta as soon as you open. And as madam has said, you can put the incision transversely above the placenta, or sometimes what I prefer for my patients is I go ahead with a midline incision. Midline uterine incision, deliver the baby and see if I can remove the placenta. If it is going to be accreta, get the consent and go straight away for hysterectomy.
Yes.
Okay, so that will be better. So then, madam has said that you have delivered the baby. Then are you going to try pulling the placenta?
If you know it is diagnosed placenta accreta, don't try, ma'am.
Don't try. Don't try. Or suppose if the patient is very keen, she doesn't want to lose her uterus, what will you do? Will you have the boldness to leave the placenta there and come out?
Sometimes we may do that, madam, and only methotrexate can give a postpartum.
Have you tried, madam? Have you tried?
Yes, ma'am. One
Yeah,
case.
okay.
Yes.
Methotrexate you have tried. Okay.
Yes.
Okay. Okay. Then after some time, what happens? Some days rather.
We have to follow up that with proper antibiotics.
Hmm.
And if the patient will bleed or whatever happened, then we can counsel for hysterectomy. If last resort, it may need.
Maybe need a hysterectomy, or there are some literature evidence to say that you can reopen her after some time. So by the time the placenta would have got devascularized, you can remove the placenta and close it. I have seen a patient delivered outside, placenta retained. She brought a bag in which the placenta was inside. She said she expelled the whole placenta in the toilet. She was lucky enough. She didn't have bleeding. Okay, so these are the steps. That is, one is manual removal. Never attempt it when it is an accreta. Leaving the placenta in situ. One step conservative. That is, what is triple P procedure? You could have heard about triple P procedure. What is that? So, Swati has already mentioned that to prevent the bleeding, uterine compression sutures, stepwise revascularization. See, what I do is generally before removing the placenta, deliver the baby, apply clamps over the ovarian ligament as well as the uterine, ligate the internal iliac if possible, and then remove the placenta. Then, if there is bleeding in the lower uterine segment, you can do the square sutures can be done. Okay, so what is triple P procedure?
Pressure, patience, like that. I mean.
So this is all these sutures, B-Lynch, all these things you know. And uterine artery ligation also all of you know. And ovarian artery ligation. So this is step by devascularization plus the internal iliac artery ligation. Or you can put this tourniquet. Okay, that can also reduce the bleeding. So, triple P procedure is nothing but we have to localize the placenta perioperatively. Okay, then pelvic devascularization should be done by radiologically placing occlusion balloons. Or if you don't have the occlusion balloons, you occlude as we do it by first stepwise devasculation. Devascularize the ovarian ligament, devascularize the uterine artery and the internal iliac. Then you put us in the non-separable placental side. You put a, madam as was telling that she will put a transverse incision above the placenta. In the lower margin also, you put another incision. You remove the entire segment of the placental tissue along with the myometrium and you repair the uterine cavity. So that is called as triple P procedure. Okay. So the sandwich procedure is something like they have mentioned that they can combine this uterine artery, that is the compression sutures along with the balloon dilatation. So anyone has got the experience of aortic compression? Do you think that it is going to be of use?
Of course.
Sir, what is your experience, sir? Aortic compression, have you given?
I don't have any experience of giving aortic compression.
Sir, and one more thing is aortic compression is possible only in individuals who are thin.
Who are thin
Our mothers are,
and once if you open the abdomen, then it is possible. Otherwise,
without opening the abdomen, I don't think
it is not possible.
It is not possible. Once when you open up, you can use the aortic clamp,
yes,
temporary occlusion clamps. Then we can go ahead with other ligations and then we can release it. So this is aortic compression. It is possible. It is just to the left of the umbilicus. You give a gentle, deep pressure and you palpate the femoral artery. I think it is very difficult practically, though it can be spoken in a theoretical way. Rekha, do you think that it will be feasible in current situation? Rekha? Unmute Rekha. She's not responding. Okay. So then uterine artery embolization, of course, in a place where we have facilities for uterine artery embolization, this will be of a much better use. So what are the prerequisites? Anybody has the experience of sending some patients for the uterine artery embolization?
Yes, we are doing, but only in gynae patients we are doing, but
Yes.
not for emergency cases, because we cannot bring our devices from radiology department to labor room or to OT.
So we had one patient, after doing even an obstetric hysterectomy, she was not comfortable, her BP hasn't picked up. So that patient, we had sent her for an uterine artery embolization, arteriography, and we found that there was a leakage in one particular place. So after doing that embolization, she was all right. So rarely in cities where you have the facilities, maybe it will be of use. Okay, so I think... So what will be the precautions you will take, Swati or whoever is available? Saroj, madam, what will be the precautions you will take when you are doing obstetric hysterectomy?
So you have to keep the blood products, ma'am. You have anticipate bleeding. Again, during the hysterectomy, the notorious part is to dissect the bladder to do the total hysterectomy.
Yes.
But here, subtotal is not, helpful. So you have to go for total hysterectomy, and bladder may be adherent, and that is the main point where you can injure the bladder. You can use the stent for that before going for hysterectomy.
Where you are having this problem, the adhesion of bladder, why?
This is a case of placenta accreta, I think. We are discussing
In
about.
placenta accreta, you won't have that much of problem, madam.
Sometimes
in
maybe.
Parkrita, you will have
Parkrita, yes, yes.
Only in
Parkrita will
cases
have
you will have this
problem, but accreta, like how sir has said, it may not have problem, but still bladder injury can happen and we have to be very careful. And
Careful,
the
yes.
most important point is never do a subtotal hysterectomy for this placenta previous. Always go ahead with the total hysterectomy.
The basic thing is, madam, the thing is all the clamps and all the they should be very small. You should go on ligating and clamping very small areas.
Yes.
Do not try to have bigger stump. Bigger
See,
stump will always lead to bleed.
Up to the uterine artery, I put the clamps, then cut it. So once when I reach the uterine artery, then ligate everything. And finally, when we, as you have said, when we come to the cervical part of it, we have to be very careful. Now, this patient has got a bleeding of more than 2 liters. How are you? What will be the protocol of giving transfusion?
Massive transfusion protocol should be initiated. Right?
Yes, what is massive transfusion protocol?
If we require more than 4 PRBCs, then we have to go in the ratio of 1:1:1. Plasma, FFP and PRBC in the ratio of 1:1:1.
Plasma or platelet?
Platelet, sorry.
Platelet.
PRBC
So,
and FFP.
which one will you give first? Will you give PRBC first or will you give FFP and platelets first?
PRBC, madam.
PRBC. No.
PRBC. No.
Yes.
No.
Be the reverse. Fresh frozen plasma and platelet should be given
FFP
first. And you try to maintain the dilution of the blood should be there. Then only after giving this only, then you give the PRBC. Once after giving 4 units, make 1 after 1. Okay, all the 3 things can be given. Oh, okay. So, sir, you can tell me what are the learning points? What is the message would you like to give to the participants from this particular patient?
Sir, in placenta accreta patients, when we diagnose, we should be very careful, and preoperatively we should be very much ready. With blood products, number 1. Then we should have detailed discussion with the attendants and with the patient. That she may go for hysterectomy. There might be injuries to the nearby structures like bladder, urethra, etc. And regarding anesthesia, though we have said it can be done under spinal and epidural, I will still believe that it is achieved the general anesthesia which should be method of choice. Definitely anesthetist will have to be some experienced person. And then your active management of third stage of labor, agreed, but placenta may not be delivered at all. And we should accurately this is the blood loss. Oxytocics are to be given. Stepwise devascularization, but if the uterus is not contracting or if there are bleeding still, we should always go for hysterectomy, because if you delay hysterectomy, there might be starting of DICs.
Yes.
And at that point, doing hysterectomy is of no use.
So you should have a lower threshold for doing hysterectomy in these cases. Okay, I think that's all what we have mentioned, discussed. We have discussed about the massive transfusion protocols also. And then, do you think that there is any use of role for thromboelastography in these cases?
Elastography.
Thromboelastography. Anyone had the opportunity of doing thromboelastography for patients with sort of needing massive transfusion protocol or massive PPH?
No, I am yet to do it.
Yes, ma'am.
Not yet.
Not
Not
yet.
yet.
Not yet. But in there are many places where they have this thromboelastography, because that is one thing. When you can get the results within half an hour, it will give you, based upon the clotting time, bleeding time, and the fibrinogen level, the platelet thing, everything, it will form a particular graph, and it will give us an idea which is the substance that has to be transfused. Okay, so I think we can discuss thromboelastography separately in another program. So anyway, I think this is whatever it is, ultimately, we have to have a clean record of all these events that is going to save our skin from the court of law. So thank you so much, all the participants, and thank you, sir, for your expert comment. Thank you. Thank you so much.
Thank you, madam.
Thank you, ma'am. Thank you,
So
sir.
obstetric hemorrhage is a fast, furious, frightening with our prompt handling of the situation and using a bit of our treatment protocols, we can surely save the patient, prevent her from mortality and morbidity. Thank you.
Thank you.
Thank you, Ramani madam. Wonderful presentation.
Thank
Sampath.
you, ma'am.
Yes, Radhika.
Thank you so much, ma'am.
Hmm.
Ramani ma'am, wonderful.
Thank you.
As usual, you mesmerized us, ma'am. And Sampath ma'am, thank you so much for the opportunity to participate as well as to coordinate. And we have listened to all the lectures, both by...
Thank you, Das sir, for being there till last minute.
Yes, ma'am. And all seniors, thank you so much, all teachers, ma'am. And literally, every obstetricians are working on a tightrope these days. And this is one of the most important preventable mortality. And hence, we all have to attend these webinars, because everyone will not face all the situations. So in this, we have to learn from the seniors, teachers, and we should, knowledge is power, and thus we can protect ourselves from litigations and protect the life of patients as well. So obstetrics is a really exciting career. I think we all, especially youngsters, should attend these meetings and empower ourselves with the knowledge. Thank you for the attendance, Dr. Ginni Gupta ma'am, Dr. Manu Singla ma'am from Ludhiana Society, and Dr. Das sir, and Dr. Swati, Dr. Saroj, Dr. Sharmila Pradhan, Dr. Rashmi Ranjan Rao for attending the panel. And I thank Professor Saraswati Sanya Chaudhary ma'am and Dr. Ojaswini Patel ma'am for their presence and gracing this webinar. I thank Dr. Mangala Devi ma'am, Dr. Nirmala ma'am from the Bangalore Obs and Gynae Society, And thank Ojaswini Patel ma'am and Leena Baru ma'am from Burla Obs and Gynae Society. I thank Ramani ma'am for a wonderful presentation, and always she's present and she's teaching us, guiding us. And thank you, Dr. Madhumita also for organizing. Until yesterday, she had gathered all the CVs and organized, and she was unable to attend due to an emergency situation. And I thank Sahiti for her online support. And thank you, Sampath ma'am, once again for the lovely webinar. Thank you, ma'am.
Thank you. Thank you
Thank
all.
you.
That's
Thank you,
Thank you.
Sampath. Thank you
Thank you,
all.
Ravani madam.
Thank
For
you all.
last
Thank
minute.
you.
Thank you. Thank you, madam. See you.
Thank you, Sampath madam.
Rekha is there. Okay. Thank you. All the
Rekha,
best.
wonderful presentation. Thank you so much, ma'am.
Thank you, Das
Thank-
sir, Ojaswini, Leena, all talkers. Thank you. Delegates, thank you.
So
Thank
wonderful
you so much.
webinar. Thank you, ma'am.
Thank you, ma'am.
Thank
Thank you, madam.
Bye.
Thank you, sir.
Thank you all.